New year, new you, or at least new scrubs. And honestly, that's a great place to start. If you're in healthcare, now is the perfect time to upgrade your uniform with FIGS. They're lightweight, durable, incredibly functional, and so soft you'll wonder how you ever wore anything else. Because let's be honest, your shift doesn't start when you clock in. It starts the moment you get dressed, and what you wear sets the tone for your day. That's why FIGS has become a go-to. FIGS makes scrubs for modern medicine. When I was in nursing school, the scrubs were boxy, scratchy, and so unflattering. They honestly felt like punishment. FIGS came along and said, oh no, these scrubs are flattering, insanely comfortable, and made with real healthcare professionals in mind. They're antimicrobial to help keep you protected, tough enough for endless washes, and stylish enough that you don't immediately change the moment you leave work. With new limited edition colors and styles, FIGS is serving a true uniform refresh. From scrubs to outerwear, footwear, and accessories, they've got everything you need to look polished, feel confident, and handle whatever your shift throws your way. 2026 is here, so let's do this. Take 15% off your first order at wearfigs.com with the code FIGSRX. That's wearfigs.com, code FIGSRX. Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips to help you thrive in school and at the bedside. So this week, we're talking about a very common surgical procedure that you'll mostly see done in children, and that is the tonsillectomy and adenoidectomy, which is often just referred to as a T&A. So this procedure involves removing the palatine tonsils and the adenoids. Again, it's a super common procedure, but it's definitely not one to be taken lightly because it directly involves the airway. And anytime we're fussing around with the airway, we want to be hyper vigilant about watching our patient for complications. It can lead to things like airway obstruction and even post-op hemorrhage. So before we dive into the nursing care of a patient recovering or who's gone through a T&A procedure, let's do just a quick review. So those palatine tonsils sit on either side of the oropharynx at the back of the throat, and the adenoids, which you may hear referred to as the pharyngeal tonsils, are located in the nasopharynx behind the nose. And little story here, I had a friend growing up, her name was Lisa. Lisa, if you're listening, hello. And she snored so loud. She snored so loud. And it was because she had enlarged adenoids. She had her adenoids removed, bam, snoring problem resolved. Now, these tissues are part of the lymphatic system, and they do tend to get enlarged in early childhood. As you know, the immune system is kind of going gangbusters at that time. It's very active. So those tissues do tend to get enlarged. Now, the T&A procedure is performed for a variety of reasons. Maybe the child has recurrent tonsillitis. Maybe they have obstructive sleep apnea, like my friend who was snoring really loud. Maybe chronic nasal obstruction or recurrent ear or sinus infection. So quite a bit of reasons why someone would have these tissues removed. It's performed under general anesthesia, typically as an outpatient procedure, though if you've got a really young child, like under 3 years, or maybe someone who's at risk for respiratory difficulty, they're going to probably be staying overnight in hospital. The tissues are removed through the oral cavity, and the procedure overall takes about 30 to 60 minutes. Now, before we get into all of the details, I do want to tell you very quickly about some complications. One is swelling and closure of the airway. Huge complication. We definitely don't want that to happen. Hemorrhage can occur. It's going to be at a higher risk for those children over 6 years of age. Dehydration because their little throats hurt and they don't want to drink any water. Permanent voice changes can occur, and infection is also a risk. Of course, with any surgery, with this procedure specifically, we're removing part of the lymphatic system, part of the body's immune system. So highest risk is going to be children who have that recurrent otitis media or recurrent tonsillitis. So now that you've got a little bit of some background knowledge, a little bit of review under your belt, let's go through this with the Straight A Nursing LATTE method as though you are taking care of this patient after their surgery. So first off is the letter L. How does the patient look? Basically, what signs and symptoms, what things are you going to notice about this patient? So a pediatric patient undergoing a tonsillectomy and adenoidectomy. I guess that's why we just call it a TNA. That's a mouthful. So a pediatric patient undergoing a T&A will most likely have a history of things like I just mentioned, recurrent tonsillitis, recurrent otitis media, chronic sinus infections, or that obstructive sleep apnea, the snoring, the daytime sleepiness, the disrupted sleep. Now, remember, children with recurrent otitis media, especially when they're little and language is developing, could have language delays. So that could be something that you notice in your patient. After the procedure, one thing you'll notice is the absence of any external incisions. Both of these tissues are removed through the oral cavity. Other elements of a typical post-op patient that you'll notice include they're going to have a sore throat, 100%. That's probably going to be one of their biggest complaints. They may also have ear pain. This is referred pain. It's very common after this procedure. In some cases, the ear pain is more significant. They could be refusing to eat or drink due to pain or very reluctant to eat or drink due to their pain. And let's say you're looking at this child, a couple days after surgery, they could have these white grayish scabs that develop at the surgical site where those tissues are removed. Now, next, we want to talk about how we are assessing this patient. That very top level assessment is going to be airway and breathing. So first off, let's monitor the child's work of breathing. It should be unlabored, just as you would expect with any post-op patient. If the child is having labored breathing, you definitely need to intervene and assess more deeply. We're also going to keep an eye on the child's SpO2, and we could even consider using end-tidal CO2, especially with a child who's really sedated, as end-tidal CO2 or watching that capnography can catch hypoxia more quickly than pulse oximetry can. And we're also assessing lung sounds. Now, we want to pay attention to snoring. Snoring is pretty common after surgery and typically is associated with partial airway obstruction because the relaxation of the soft palate and the tongue kind of drifts back. And that can usually be easily resolved with positioning. And other times, snoring could be due to a little bit of edema in the airway, maybe a little bit, just a tiny bit of airway obstruction. When it gets serious is when we have stridor, and we're looking here at a very significant airway obstruction that could go to complete closure. So we want to keep a very close eye on that. That can be due to edema. It can be due to laryngospasm, but edema is probably the more likely cause because we are, again, working in the airway. We also want to monitor the child for bleeding. This, ding, 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 this will be on an exam. So this surgery does not require external incisions. So the bleeding that occurs is going to be bleeding internally, a little more difficult to spot, especially initially. So the patient could, of course, have visible blood oozing from the mouth, maybe the nose, but since we're going through the mouth, that's where it's most likely to occur from. But some other signs of bleeding include, number one, frequent swallowing. And this is what will be on your exam. It'll be a question like you're caring for a post-op patient who had their tonsils removed and they are swallowing frequently. What are you going to do? So the obvious answer is I'm going to be very concerned about bleeding and I'm going to be notifying the surgeon. Another sign of bleeding is frequent throat clearing. Now, we want to be very, very careful with a child who is clearing their throat. You want to encourage them not to do that, but if they're clearing their throat because they have bleeding, that makes sense, right? So be very suspicious if the child is clearing their throat a lot that they could be bleeding. Now, the reason we don't want them clearing their throat if they're not bleeding is because that could dislodge any of the hemostasis that has occurred, and then they could begin bleeding. And then later signs of bleeding are going to be things like pallor. Hopefully, it doesn't get that far, tachycardia, and hypotension. Now, the child is going to ingest some blood, not a ton, but in most cases, it's going to be pretty unavoidable. They're going to ingest some blood. Even the patients that I would take care of after dental procedures would ingest a little bit of blood because they're, oozing throughout the procedure. So, what that does is it causes nausea because blood and the GI tract just don't mix. The body knows that it shouldn't be there. So, the child may complain of nausea initially. That's very, very common. And if they are vomiting, it could be bright red. If it's bright red, this is not good. This is call the surgeon immediately type situation. But it could also have a coffee ground appearance. That's older blood that's been ingested. And I know it sounds kind of gross, but basically partially digested. And that's what you would see. So again, nausea and that vomiting of coffee ground emesis. If it's a tiny bit, probably to be expected. If it's a lot, we are definitely going to be very concerned about blood loss. And if it's bright red, that looks like there's clots or, blood that's actually more fresh, we are very, very, very concerned. Other key assessments include, of course, evaluating the patient's pain level. We are going to make sure that we use the appropriate pain scale for this. So there are different pain scales. There are observational pain scales and there are self-report pain scales. And basically, we want to make sure that we choose the proper pain scale for your patient. You wouldn't ask a 2-year-old to rate their pain on a 0 to 10 scale. They can't do that. So we can use things like the FLACC, FLACC scale. This is an observational scale for children older than a year who are not able to self-report. So this would be a child who can't speak, isn't understanding what you're asking, or a child who has developmental delays. We also have the Wong-Baker Faces scale. This is the one with the cartoon faces, and there's like a happy face for no pain and a really sad crying face for terrible pain. So this is used for children over 3 years of age who are able to self-report, and they do this by choosing the little cartoon face that matches how they feel. And then, of course, for children that are a bit older, the numeric scale, totally appropriate for a child over the age of 8 who is able to self-report. So that's a key one, evaluating their pain level. And we also want to monitor hydration status. These children can get dehydrated very easily because, again, their little throats hurt and they don't want to take in any fluids. So we're monitoring hydration status by keeping an eye on their mucous membranes. We're looking at their tears. Are they crying? Without tears, that's a sign of pretty good dehydration there. And we're also watching their urine output. And then we're assessing their sedation level, just as you would with any patient who has undergone anesthesia and any patient for whom you administer opioids. So next up is the letter T, and that is for tests. What tests are utilized with this procedure? So there really aren't a lot. Most patients undergoing a TNA don't really require any specialized testing, though some pre-op testing for obstructive sleep apnea may occur in those children who have the sleep disorders. Other tests you may see would be more for monitoring for complications like bleeding, and that would be coagulation studies and the hemoglobin and hematocrit. And then if the patient's at risk for infection or we think they may be having an infection, a CBC looking at that white count. Now, another T is treatments. What treatments are we providing after this surgery? So the key treatments are, first off, pain management. Patients are going to have that significant throat pain, maybe some referred ear pain. So common options include acetaminophen, ibuprofen, and opioids may also be used for severe pain in that, in that close post-op period, that immediate post-op period. Note that opioids are going to be used very sparingly and with a lot of caution in your child who has obstructive sleep apnea. Hydration is another key treatment. We want to be encouraging fluids for these kiddos. Again, they may not want to drink because their little throats hurt. Offer things like popsicles that are kind of irresistible, or maybe ice chips for an older child if they're not down for a popsicle. That'll help provide hydration and it will also provide comfort. So then maybe you can actually get them to drink some water as well. Nutrition is going to come later after the child's able to tolerate those fluids. We're going to start trying to get them to eat. And we're going to be keeping that to a very, very, very soft diet. Things that are really good are also on the cooler side, like puddings, applesauce, yogurt, ice cream, cold foods. But they could also have other things like mashed potatoes, pasta, pancakes, stuff like that. It's soft and we want to get some food into them. And then we're also going to prevent bleeding as much as we can. So we're going to do that by trying to keep the child calm. If they're crying a lot, we want to try to alleviate that by treating their pain, comforting them, getting their parents in there to hold them, whatever we can do to keep them nice and calm. We want to discourage coughing and throat clearing, as a vigorous throat clearing and coughing can cause bleeding. And we also want to just keep the child kind of in a resting state. They're going to avoid vigorous activity. Now, bleeding can occur anytime post-op, and the risk is really, really critical in that first 24 hours in that immediate post-op period. Now, before we get into patient education, let's take a quick break because there's a ton of education coming up. Since patients do typically go home, it's going to be the caregivers, the parents, who need to know a lot of things about caring for the little one after a tonsillectomy and adenoidectomy. The holiday decorations are coming down. There's no longer an endless supply of cookies and chocolate in my kitchen. It's basically that time of year when I like to treat myself to a little something special, or maybe a few little somethings special, which is where Quince comes in. Because Quince partners directly with manufacturers, they're able to pass their savings on to you. So you can get luxurious clothing and accessories at prices that are 50 to 80% less than similar brands. Now, I've got my eye on a couple of things that I think will go a long way toward brightening my winter mood. One is a dolman sleeve cashmere sweater that's priced at just under $40. And the other is a lightweight puffer jacket that's just $79.90 that I plan to take with me for some hiking in Sedona in a few weeks. Treat yourself this winter without the luxury price tag. Go to quince.com/nursemo for 365-day returns plus free shipping on your order. That's QUINCE.com/nursemo to get free shipping and 365-day returns. Quince.com/nursemo. So the final letter in the latte method is an E, and that is for education. What education are we providing after the T&A procedure? Again, key element here because most likely little one's going home and the caregivers, the parents are going to be the ones who need to know what to do. So here are some things that you want to make sure are included in your teaching plan and that are printed out and ready to send home with those caregivers. So in the first 2 weeks after surgery, it's really important that the caregivers understand this little one's going to be more susceptible to infection. So they don't want to have their child in crowded environments or around anyone who's actively sick. And they'll also be advised to stay home from school or daycare for a period of time. 1 to 2 weeks is pretty common. Voice changes is another thing that can happen, and that can be pretty normal after surgery. But if the child is hesitant to speak or speaking at a really low volume, like whispering, for more than a few weeks after surgery, you want to contact the physician just to make sure that there wasn't any damage to any of the nerves that are involved in speech. You also want to make sure that the parents or caregivers know the child needs to avoid strenuous activity, definitely avoiding sports for 2 to 3 weeks after their surgery. and that they may feel nauseous. And this is pretty normal for about 24 hours after surgery. And this is, again, most likely due to ingesting a small amount of blood and also just because of the medications used in anesthesia. If the child vomits, it may be slightly blood tinged. This is generally okay. It's when there's larger amounts of blood that we're going to get concerned. Now, a sore throat is another very, very common thing. It's expected for several days after the procedure and typically is going to be most severe kind of around days 5 to 7. And this can surprise a lot of parents when they feel like, okay, the first few days are going to be the roughest, but then it's actually gets a little bit worse. You're going to be teaching the parents or the caregivers to treat this with medications as prescribed. Most likely, it's going to be like acetaminophen, ibuprofen. In some cases, there could be opioids involved. We're also going to be giving this little one cold fluids, ice chips, popsicles, things like that to help soothe their throat. Now, they could also have an earache or jaw pain. These are referred pain symptoms, pretty common after this procedure. Another thing that can be common after the procedure is snoring and mouth breathing. This is because there's a little bit of inflammation going on. The child's breathing should return to normal within about 10 to 14 days. And then a low grade fever, pretty common after this procedure. Anything up to 101.5 is considered low grade. It can be treated with acetaminophen or ibuprofen if it makes the child uncomfortable. Now, another thing that people might be a little surprised by is how stinky their child's breath is after this procedure. That's because of these scabs forming. It's not necessarily a sign of infection. You would want to teach the parent that if the child has a fever and really bad breath, that could be an infection, but just general bad breath after the procedure is normal and it can linger for about 2 weeks. Speaking of the scabs, they look like whitish patches and they're going to be in the back of the throat at that surgical site, and they should disappear in about 2 weeks, taking their stinkiness with them. It's also important that the caregiver know to encourage hydration. Don't just leave it up to the little one to drink on their own. They have to actively encourage it, again, because their little throats hurt. So, a child up to 2 years of age is recommended to get about 16 ounces of fluid a day. 2 to 4 years is about 24 ounces of fluid a day. And 4 years and older is about 32 ounces of fluid a day. And they can keep an eye on this by monitoring their urine output. They can look at mucous membranes, things like that. Look at those tears. If they're absent, they're definitely not getting enough to drink. But those are some general guidelines for how much fluids. Now, some physicians do recommend avoiding straws. Others say it's not necessary. You're going to teach the parents and caregivers to do whatever their surgeon says that they should do. And as far as nutrition goes, sticking to those soft foods for about 2 weeks. Again, good options are pastas, mashed potatoes, pudding, scrambled eggs, pancakes, ice cream. I mean, that's all stuff kids love anyway. They want to avoid crunchy foods, spicy foods, and citrus foods, which could all be incredibly irritating to their tender throats. Now, another key thing is to make sure the caregiver knows when to call the physician and when to seek urgent medical care. In addition, they should understand that the child should be advised to stay within 30 to 45 minutes of an emergency room for the first 2 weeks after surgery. And the surgeon may even have specifics about staying within 30 to 45 minutes of the particular emergency room associated with their hospital that has an ENT specialist. So make sure that they understand their travel limitations during this time. Other important things to teach that are more critical based include seeking medical care if the child has signs of infection. And that goes without saying, right? That's any post-op patient. That's going to be a fever above 101.5. For this child, it could be really, really bad breath, maybe breath that worsens along with the fever. Maybe it's things like yellow or greenish mucus, typical signs of infection. You want to make sure they know to contact the physician for signs of bleeding, including spitting up blood clots, vomiting blood, having coffee ground emesis. They need to make that call. If the child's actively bleeding, this is a seek medical care immediately type situation. And again, this is most likely to occur if the scabs fall off early. or when they do fall off. But if they fall off early, it indicates that that tissue is not quite healed. So bleeding can definitely occur. This can also be due to coughing vigorously, throat clearing, things like that being too active. So those are all reasons that bleeding could occur. You want to make sure they understand that if the child has any difficulty breathing, they need to seek medical care immediately. Also, if the child is unable to swallow, indicated by drooling, this is a sign that there's a ton of swelling in the airway. This is an emergency. They need to seek medical care. They should also let their physician know if the child's nauseous or unable to keep fluids or food down beyond that first 24 hours, because we do expect that nausea to resolve within that first day. And then again, the child's not drinking enough and they're concerned about that. They need to call. Signs of dehydration again are decreased urine output, dry mucous membranes, and crying without tears. So there you have it, your quick overview to tonsillectomy and adenoidectomy. These are pretty darn common pediatric surgeries, but it's important that we understand as nurses they're anything but routine. We have to keep a close eye on airway, keep a close eye on bleeding, also their pain control, and their caregiver education are really, really important components to keeping these patients safe and giving them a good recovery. Now, make sure you check back on Monday in just a few days, and we will do a pod quiz about this episode to make sure that you are ready for your exam on this topic. See you then. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.